Here's something most people in health policy don't think about. Medicare fee-for-service processes well over 1 billion claims, pays out something close to $500 billion in actual medical cost. And the systems that do this were written in COBOL back in the 1970s. And policy changes take up to a year or more to implement. And there's no real-time claims adjudication for the most part. These systems have nightly downtimes and dark days. And the organizations that run all of this are called Medicare Administrative Contractors, or MACs. There are fewer than a dozen of them, and they run all of the operational backbone of original Medicare. They process every claim, enroll every provider, handle appeals, make coverage decisions, and almost nobody in the policy world talks about them except for us. And we think that's changing now. CMS has launched this new idea of Claims Core, an effort to replace legacy systems with a cloud-based real-time platform. They want sub-second adjudication, modern APIs, configurable policy rules. If it works, it's the biggest change to Medicare operations in 50 years. Today, I'm talking with Brian Janssen. He's the CIO of Medicare at WPS Health Solutions. WPS runs 2 MAC jurisdictions, processes at least 130 million claims a year, and also administers TRICARE for life for 2.3 million military beneficiaries. We're going to talk today about what MACs actually do, why it's harder to innovate in the space than anyone realizes, what Claims Core might mean for the future of Medicare, what it takes to deploy AI when you're operating under FSMA high security in a CMS-owned data center. So Brian, welcome to the podcast.
Well, thanks for having me, Lisa. I always like it whenever anyone has a topic about MACs. I was introduced one time at a conference years ago, and they correctly said MACs are likely the largest backbone of processing in the country that the healthcare world doesn't really know about. And I think there's a lot of truth to that. So again, thanks for understanding that we exist and bringing us into the policy topics.
Yeah, absolutely. I mean, I learned about MACs obviously working on federal health policy at CMS, but also at the time, at least when I was at CMMI, WPS was the innovation payment contractor. So maybe you can just give us a bit of an intro about WPS, where you sit in the MACs world and all the work that you all do.
Absolutely. WPS actually has a very long history as a MAC, well before they were actually called MACs. We're actually founded in 1947 at the end of World War II, when service members were coming back from war and the state and the federal government were looking for ways to administer their claims. Right now we've got 7 contractors that work on 16 different MAC jurisdictions if you count DME, but that wasn't always the case. We had 35, 40 different processors prior to kind of that rebranding as a MAC, and WPS themselves has been here through all of it, right? Since, the very first federal payment. You mentioned TRICARE. When it comes to our DoD roots, very similar. Starting in 1947, we're processing on behalf of service members. So our roots with the federal government go incredibly deep. And we've seen the change from the fiscal intermediaries to the MACs to how do we go from 35, down to the current 7. So we certainly have a long history to draw on and a lot of experiences. So again, it's a great organization to work for with those deep roots.
Yeah, definitely. So I think a lot of people may understand, okay, federal healthcare programs, their federal health insurance, again, for Medicare beneficiaries or for military service members or their families, or veterans, right? That kind of can make sense. Okay, somebody has to actually run and operate the claims, process the claims for all of those programs, regardless of who pays for them. But there's a lot more that MACs do if we just stick to, for the moment, to the Medicare side, right? So, you do, like you said, the provider enrollment, the sort of appeals process, some of the medical review, and then there's this thing called the local coverage determinations. Can you explain that for folks who aren't intimately familiar with like what does claims processing look like at a regional level?
Absolutely. So when the Medicare program was really devised, and I'd say this goes back to 2003 when they came up with different regions, one of the core tenets of the Medicare program is having a federal kind of umbrella with national policies, national benefit determinations, but also having a regional influence. If we look at what are the needs in Florida versus Texas versus Wisconsin, we're going to find very different medical conditions among the beneficiaries. We're going to find different needs among the providers. One of the current core tenets is how can we reduce fraud, waste, and abuse, which is going to look very different in Illinois versus California. So when it comes to like the LCDs and that local focus, it's really how do we have a national program, but still allow flexibility where we can look at the medical needs of our local provider, of our local population of beneficiaries, and what do those specific providers need to reduce their burden and administer care. So it's a real interesting program, kind of like the Blues, where they have like a national umbrella, but very localized abilities to make decisions and really cater to their customers.
Can you give some examples? I mean, I think we saw potentially that there were differences in different markets around the potential fraud, waste, and abuse around skin substitutes, for example. Can you give an example of where a LCD might be important, or what's the difference at the local versus the national level?
So the skin treatments is a great example, right? I would say for the most part, we have a pretty uniform system even at the local level, because CMS encourages us as MACs to work with each other and to work with them to ensure that we're not causing very different types of medical policies from one state to the next. If you think of what that would do to like a United or an Aetna or Humana, when it comes to some of these larger facilities. Now, when we do have issues, you kind of picked up one of the largest of recent, when we have local determinations, national determinations, and how is that kind of in alignment or not in alignment with the entire medical community. So I think a lot of times what we see in the news is certainly some of those corner cases, as opposed to a lot of the local coverages that have to be in alignment with a national policy. And we try to reconcile across the jurisdictions before they go into place.
Mm-hmm, mm-hmm. And I think maybe if you were just totally outside of the space and didn't understand the complexities of processing claims and dealing with enrollment and appeals and review and things like that, you would say, okay, there's just basically a basic utility. You can replace one with the other. What are people getting wrong when they say that, claims processes are just utilities?
I actually used to be one of them. And I can say this, right? Because most of my career has been in the commercial space, which is where when I came into federal contracting, I was a little bit blown away going, why do we need this, right? Mm-hmm. And how does this even make sense? But I know for me personally, it was the scale and the breadth of the different populations across the nation, the size of America. Right? When I look at our own jurisdictions and I watch the news and I see like Flint, Michigan, and all of the environmental concerns having health impacts on the health of the local residents, now I'm thinking, okay, in that jurisdiction, how does CMS and the Medicare program have to align like local policies to account for that kind of uniqueness? Or when we see rural health, and I know when it comes to rural health clinics, that looks very different in Kansas, in Southern Illinois, than it does in Michigan. So it sounds much easier. And I think if we were a lot smaller of a country with a little bit more uniformity between rural and urban and our overall health, then we may not need that type of like federalized approach. But, I look at Wisconsin, where I'm from, and I see our health concerns, which are significant, but compared to an Alabama or a Colorado, it's trying to prepare to take care of those regional populations as well. So, when I came in from commercial myself, I wasn't used to just the pure scale and the different populations. Like when we talk about fraud, waste, and abuse, now we have the national moratorium, for example, in play, but certain regions have had that historically. If you in like California, they have a very unique hospice situation than we do in Wisconsin. So would it make
you need more focus on that in particular markets because the market concentration is different and the practices are different. So you have to just know that.
Absolutely. And if I had $10 to spend, would I spend it in the same place if I was Florida or California versus Wisconsin or Iowa? No, one may be focused more on fraud, waste, and abuse, and the other more on how do we keep some of these rural clinics up and thriving.
Yeah, that's really interesting. I think it is very, very different. I like to remind my my Medicare for All friends that even in Medicare for All, you need claims processing because not every claim is going to be approved, and there's different reasons for that, right? There's either it wasn't safe or it wasn't effective or it wasn't approved in whatever situation. All of these national health systems have very specific rules of coverage. So, you just plus that up by however many states we have, 50 states and other jurisdictions. And so it's a lot.
I've got nothing to base this on, so take it with a grain of salt, but I would be willing to bet if I looked at my local Medicare Advantage plan and compared it to Texas or a New York, I would expect very different outcomes on how value-based care would work based on how the population of providers, like how modern are they and are they kind of thriving in that? I would think not just those variable kind of benefits that somebody can add to their plan. I think we'd likely see a lot of regional variances there as well.
Yeah, interesting. So innovation, it can be a challenge in highly regulated environments. I think that, there's often a lot of criticism for Medicare being relatively slow on things. You are and Max are generally subject to very, very strict security requirements and other regulatory constraints and contractual constraints, I assume, that make innovation challenging. Can you talk about some of those constraints that people might not know about?
Yeah, one thing that makes Max unique is the security and the amount of audits we have as a CMS contractor. When people talk about Medicare Advantage or MedSup or some of the other federally sponsored programs, it really is a different level of oversight from a MAC, which again goes back to those 2003 legislation as a high value asset. We do have a much higher degree of security. And don't get me wrong, that is a great thing. When it comes to significant breaches you see in the news, MACs really are focused on security. One of the things about kind of how MACs are actually like how the financials work. Again, we're not a typical for-profit. We get reimbursed based exclusively on performance criteria, security being one of them. And does that certainly have impacts to innovation? It does. But here's one of the more interesting things that I think back into my career is depending on what time period, I think what that impact is certainly waxes and wanes. A couple years ago when everyone was going to SaaS solutions, that is something that there's certainly a lot of hurdles to jump over. There's a lot of security, and we have to make sure that any of our partners are just as secure as we are. I think in more recent times, you mentioned some of the AI components, or we're just going to call it the shift of SaaS market. Now we're seeing organizations across finance, across healthcare, almost start to kind of pull back from that model in a way just due to high volumes and now bringing things more kind of on-prem. I'd say that build versus buy, that pendulum is starting to swing. So now we're seeing more opportunities to innovate. But again, it's so specialized on what is the processing component and what are your objectives and are there SaaS versus build factors. But it is, I'd say the security and being in a FSMA high facility is one of the biggest considerations on how you take an approach to technology and innovation.
Yeah, definitely. You had mentioned to me that when you all started working with some AI tools, you had to actually you've had to buy your own hardware, like you were just saying. Can you talk more about what that looks like? Like, how did you, like you were saying, you made that build versus buy decision, and at the time determined that you needed to have your own hardware on prem. I think that's probably not something that a lot of sort of like AI, healthcare AI innovators are thinking about. That a claims processor would say, we have to be 100% on prem. We don't have anything else we can do.
Yeah, that was certainly one of our kind of guiding factors. I have to go back to what's going on in the technology landscape now that, people want on-device models. I almost give Apple and the iPhone a lot of credit because at the time I would have said, wow, this is going to be a big limitation for us. But now things are becoming so much more efficient that it's becoming less and less of a barrier. So when you have technologies that change or double every 3 weeks, it seems like, I find my own opinion on any sort of like what is a landscape and what are those potential barriers can also change every 3 weeks. So it's been an interesting journey, to say the least. Much like whether it's our portal infrastructures, our IVRs, all of that has to be considered on, what do we have available? What are something that we're not going to be replacing every 2 years? And how can we make good long-term decisions with that FSMA high in mind?
Yeah. So what did it actually look like? You all went out and acquired infrastructure and then started training models against it. And what was involved in that process for you?
Every Mac has a FSMA high infrastructure in place. So in that regard, much of that infrastructure is already there. I'd say it's one of those places that throughout healthcare is probably the most secure data centers that at least I know of. Wow. And that'll be common across all of the Macs. Now, when it comes to how to build into the infrastructure, since it does exist already, now it really is, what are the right software components and what is the right program, right? Because I think where a lot of folks, even in that space, kind of overlook is what is the process and the methodology. If you're in a cloud or you're on-prem, like what does that look like? And how do you really focus on doing something that delivers value? I think when it comes to our overall views, that was actually a bigger learning lesson than infrastructure and hardware, which is certainly, again, just part of our DNA, as I suspect all Macs.
Yeah, I mean, I'm sure you're hearing, hey, people need to be innovating with AI. And it's like, to what end? What are you trying to achieve, right? You're probably trying to achieve more efficient processing, more accurate processing, fewer need for human beings to touch the process to speed it up, right? Like, what are kind of the objectives you were trying to achieve through the innovation you were trying to pull out of this very, very, very secure environment?
And I think you nailed them, right? What everyone's looking to do right now is not fall into that trap. And in that trap, I say those proof of concepts that typically don't go anywhere.
Right.
We've read the Pierce Healthcares and we've read the Forbes and the MIT studies. And instead take that laser focus on where are we going to get operational improvements, where are we going to really get quality improvements. In a way, I don't know if you remember a few years ago when we were all focused on RPA and robotic process automation. And then in a way, I feel like everyone forgot those lessons. All of a sudden, AI hits the landscape and everyone wants to just flip a switch, turn it on, and it'll magically take care of itself. And we're certainly finding that's not the case. Much like just like the rules engines of the past, you really have to have that outcome in mind. And then how do you laser focus any of your innovations on achieving those very granular components?
Exactly. I think in some ways, some of the things that are being sold today are very much like RPA dressed up in a fancier outfit. And, we already had those issues and those considerations to deal with back then.
Yeah. And in a way, this is a tool, right? And I think as it becomes more normalized, people are going to be putting it in, again, in a simplistic way. How do we kind of get back to the business focus? And I think as things like AI get easier, less technical, right? We watch the LinkedIn's and we see what like Claude AI or Claude Cowork is now kind of allowing at the grassroots level, everyone to start doing with AI. I can only see that filtering into all organizations, Macs included. So how is that going to even make things like the RPA a little bit easier? Because you won't need that real deep coding experience. But yet, unless you have your business objectives in mind, that I think is where some organizations may kind of miss the boat by throwing AI in, thinking a chatbot will fix every problem in the world. And then at the end of the day, you notice the needle hasn't quite moved that much.
Yeah, exactly. So maybe at some point those tools will make it into the hands of folks who are working at the Macs, but it might be a little bit of time because we're not quite in that FISMA high area yet, I would say. We'll see.
Exactly. With AI, it's just an interesting timeline compared to other tools. What normally I would say would be a 3-year journey, maybe that's 3 months. It's to predict, and what it even looks like these days, or what it'll look like in 3 months.
I couldn't predict it. So let's move on to the sort of what's next for Medicare and Medicare administrative contractors. So CMS made some noise about the release of this claims core statement of objectives, and they started talking about what they want to do with claims processing. They want to replace a bunch of the standard sort of tools or the things that are already there with a single cloud-based platform. Can you explain this a little bit more? What are they trying to do per your understanding?
So, again, from my understanding, which in many ways is what everyone else is reading as well. We look at this even in the Macs as something that's exciting, right? Because if you look at what the claims core could be, I think it's it's an initiative by the administration to say, we already have a processing apparatus in the federal systems. And for everyone else, Macs don't have their own adjudication platform or kind of core system. We have a lot of ancillary tools, ancillary technologies that have to integrate with the federal, Part A and Part B adjudication platforms, which, to your early point, they've been around for a very long time. We're looking at 20, 30-year-old systems, which makes sense exactly how they're built going back in time 30 years ago. Very, very high volumes. If we looked at the commercial world back then, who knows if anything even could have handled it.
No way. Yeah.
Right. Like we have these, mainframe is certainly a dirty word these days. It's hard to get new folks skilled up on COBOL. But what they did do back in time was process really high volumes in a very stable way. But what this administration is doing, which is incredibly positive, is now looking at it and saying, okay, what else could we have if now we make this a focus to bring this into like modern standards? Real-time processing, that's certainly one component. Interoperability, 57F, how do we tie in all these federal programs is incredibly exciting. And I think that's what they're looking at. But fundamentally, what I really give them kudos for is taking a look and saying, okay, let's look at the whole federal landscape. And does it make sense to take a more commercial approach to something? And I think the answer is always yes. You're never worse off for taking a broader view and seeing what exists and what are your options are, right? Because are you going to improve quality, efficiency? I think if we had about 3 more hours on this podcast, we could have a dry erase board and it would be huge. So yeah, it was certainly a big splash in the industry, even among the Macs. But again, when we collaborate with other Macs, everyone is excited about the possibilities and what could that deliver.
I think you make some really important points about the needed stability of the system to process a massive, massive amount of claims. Like you said, there isn't really a corollary. The commercial market has a bunch of systems that are much smaller in terms of processing. And that's not to say that anyone would be happy with claims not being processed, but I feel pretty certain that Medicare beneficiaries and their representatives would be especially unhappy if there were any kind of problem with the processing of their claims. And so that's why some of these really massive legacy systems, survive so long, even though like we've been discussing, it feels like the time has probably come. We've moved on to a point where technology has gotten better and better, and we have more flexibility on things like the UI, thanks in part to some of these AI tools, where you can have a really powerful core underlying infrastructure, and then you can use some of these new tools to make more flexible, personalized interfaces in various different settings. So you can see a technology window sort of opening, but such a critical importance of maintaining the fidelity of that underlying system that it makes me a little nervous. Now, of course, I think there's risk to do nothing as well as risk to do something, right? There's risk in both directions here. But I think, maybe let's talk about specifically some of the challenges with the legacy systems. They noted things like policy changes taking a long time, real-time adjudication, siloed data, the workforce challenges of people who no longer know how to work with COBOL systems. What else would you point out as sort of problems with the current system that we can't ignore any longer?
I think we talk about almost everything you just mentioned, because now you have me trying to wonder what other categories exist.
Yeah.
Now, to your point, stability is critical. And I'm going to say this kind of looking back a couple of years ago. If we have challenges among a lot of the nation, especially rural health, smaller clinics, people that are seeing the Medicare beneficiaries, if those claims are delayed or, heaven forbid, lost, right? If we have disruptions in the Medicare system, the closest analogy that I think I have is, when we had the Change Healthcare breach incident a couple of years ago. That
was bad.
I was shocked how fast clinics were going from surviving to now up for sale.
Yes.
Because of those delayed payments. Medicare certainly jumped in and started doing relief payments right away, but it's the closest analogy I think everybody understands on what happens when payments are delayed. And again, I think we could talk about green screens. We can definitely talk about APIs and interoperability, which is certainly a challenge when it comes to the older platforms. I think a more modern infrastructure will certainly give us, much more functionality. To your point, when it comes to even new hires at a Mac, having a user interface that looks, more like a PlayStation than it does a green screen. We just do have to be careful when it comes to not interrupting those payments, because for me personally, I think I saw through that clearinghouse incident how kind of fragile many of our smaller provider networks really are. And we certainly don't want to interrupt that.
Yeah, that's a really good point. I remember there were GoFundMes and, news articles everywhere. And like you said, clinics being at risk of closing. It happened very quickly.
But these things are not mutually exclusive at all, right? Depending on how you deploy a new platform, you can run these things in parallel until you are very confident that we're going to have payment accuracy. We can deploy things in ways that encourage stability and lower the risk. So, none of this is mutually exclusive, like new platform equals high risk. It's just, how do we start to take some of the lessons learned on the new platform or whatever that may be, and then just deploy it in a way that we can give every provider in the country some really good assurances that their payments won't be disrupted, or their burden isn't going to skyrocket. And there's many ways we can talk about on how to achieve that.
Yeah, definitely. One of the things that they talk about in the SOO is and I think Chris Klomp has also mentioned many times. Chris Klomp, I think he's now still the director of Medicare, but he's also more or less over all of HHS now, as far as we can tell. I'm not sure if he's still fully in his Medicare role, but he's talked a lot about, very, very quick adjudication, paying providers sooner as some of the objectives. They talked about the sub-second adjudication, and then, like we said, really dynamically implementing policy changes across the claims system. How realistic is this? Medicare has hundreds of thousands of billing codes, thousands, I assume, of coverage rules. Like we've talked about, local coverage jurisdiction determinations versus national. There's different rules for regions. How realistic is it to get to sub-second adjudication of claims at scale? I'm sure there are some you could probably adjudicate very quickly, and some you absolutely could not.
Well, I think we're gonna have to talk about this at so many different angles, right? Because is it realistic? Yes. Now, if you ask me the time period, here's one of the things that I think as part of that conversation, we have to understand how the providers are going to be hooked in with us. For example, could we process sub-second? Absolutely. But would that require some sort of transformation on claims receipts and giving back? Today we take in 837s, we push back 835s. And a lot of that, for example, is batch run. Right? Can we get over that with the new fire?
These are electronic claims formats that are being transferred in batches, or being processed in batches. Of course, they're not real time. And
this is where I think we can't talk about it in a silo. What I have, frankly, really liked hearing from when it comes to the presentations by Chris Klomp and Amy Gleason and Kim Brandt is that they are taking into account, if we're going to do this as a sub-second adjudication, okay, how does that work with 57F, interoperability, fire? Because providers themselves, if you're a rural clinic and you're still saying, I can afford a fax machine or I can mail some paper, that's going to be very different than working with Mayo Clinic, Cleveland Clinic. I'm going to name every United, any Optum facility that can have a robust fire-based hub, right? I think we've got to understand interoperability to get the information to us to process and then the payments right back to them. What I also like is all the discussions on fraud, waste, and abuse, because that would also necessitate a migration away from a pay and chase now to the term stop and interrogate. And I think that is a win-win. So do I think it's realistic? Absolutely. But do I think we have to look at it in conjunction with a lot of other programs that right now are being discussed? Yeah, and they have to line up.
Yeah, if you do sub-second adjudication, then you are paying and chasing if there were any issues that you discovered in an audit post. So, they've talked about things like gold carding in some of the new programs. That's where you would say, well, this provider has a very, low percentage of sort of suspicious or unfounded claims, I guess, and has a great record of, following the coverage rules. And so, maybe they are eligible for sub-second adjudication and earlier payment.
That's a great example, because we do have that today, right? When it comes to prior authorizations across the Medicare program with continued demonstrated, let's say performance, but, lack of doing everything correctly, then suddenly they become exempt to that. So that could be a great way to kind of tiptoe into it.
You bring up a good point as well, which is that, people maybe falsely expected that there was no prior authorization at all in original Medicare. That's not true. There's prior authorization. There's been a prior authorization in different areas, including DME and a few others, I believe. So you all are responsible, and other MACs are responsible for doing different types of prior authorizations.
We are. We've got 7, which is very different than the commercial world, and that's base. Some jurisdictions are certainly having more, but so now there's another good example of where can we have real-time adjudication if it's something that requires a prior authorization. We're going to have to just kind of bake that in. I think a subset of claims from providers with the right interoperability components, absolutely.
Yeah, definitely. Interesting. So Macs can't respond to the claims core RFI or this part of the process, and they're going to be doing kind of a challenge-based acquisition as well. So vendors are competing over a period of time to sort of prove out their ability to do this work. What are your thoughts on that, and what's your perspective or your vantage point from this as a Mac watching this happen?
So I may be a little bit odd, and I only say that because, again, coming from the commercial world, whether it's Chili Cook-Off, whether it's Wiser, whether it's kind of this new, how they're going to approach claims core, I really like the philosophy behind it, right? Like, let's really try to get a best of breed system, regardless of where it is. We'll look both to government and commercial and see what happens. I think the jury's still, again, this is brand new, and we're all trying to adapt to this new way to procure goods and services. So unlike most things that I'll either have a good prediction or I'll make one up, this one, I love the concept of going broad in the healthcare markets. I think we're going to have to see who's all responding and do they get the necessary participation that I think is designed to solicit. So I think that's where most of the industry will be kind of waiting and seeing what kind of outcomes we have. But it's certainly a new way to procure.
Yeah, it's a new way to procure, and again, very prove it, outcomes based, challenge based. I think that's definitely trying to get as many commercial off the shelf solutions as possible, which again, I understand from a sort of an ideology perspective and, wanting to get the best systems. At the same time, Medicare and CMS has regulation on regulation on regulation. And so I think that's going to be the challenge is, can your commercial off-the-shelf solutions adapt to a really, really, really highly regulated market and programs, right? Medicare is not even one program. And so that's the part I think will be a little bit challenging for folks to make work.
It will be. I think we had a lot of federal lessons when it came to, the Department of Defense and the Oracle deployment. So it's not
still ongoing.
It is, right? So like the model isn't brand new. We have had little pockets of this in pretty large federal systems, and can we learn from those? You're right. It's been a longer deployment over there. So are there lessons learned that other federal agencies can utilize?
Yeah, definitely. So one of the conceits of this podcast is that we have sort of a policy stack that underlies all of this work that you do. Even if you don't work directly in policy, if you work in healthcare and healthcare technology, your work is just very much driven by policies and laws. And so when I think about the policy stack here, obviously there's the sort of the underlying federal statute, right? Social Security Act that created Medicare. And then there's, of course, things that CMMI is doing in the space, which is the Section 1115A. And then there's all kinds of CMS rulemaking. You guys probably have the same kind of thing. There's a statement of work. There's the program integrity rules. They're, in this case of Wiser, run as a CMMI program, so all of their stuff there. What else? There's federal contracting. There's a huge amount of things in federal contracting. What am I missing there?
So there's a large, I'm going to say net, right? And you're right. Within HHS, we do have a lot of different interested parties, whether it's CMMI, CPI, CMMG. And as a MAC, at the end of the day, we are a contractor to CMS. And one thing I will say that is unique among all MACs is how much they really take pride in fulfilling the CMS goals. You're right. There is layer upon layer of contractual approvals, federal legislation. at the end of the day, when we kind of get our marching orders and directions, you're right. There's a lot of I's that get dotted, T's that get crossed. And as we get a more, well, not worded, but as we have more and more interested parties, it's really up to not just the max, but also all of our contracting officers and us to make sure that we're aligned with really the federal agency itself. So
Yeah.
you're right. We have a lot of filters as a Mac or
A lot of filters, a lot of layers, and then security and compliance. You have like FISMA, High, FedRAMP, CMS, acceptable risk safeguards, AWS Gov Cloud requirements for Claims Core, which is coming up potentially. So all kinds of security constraints and rules and policies that determine what you can do.
Yeah, I see my hats off to we call it the DIMSU team, which is the Mac security group at CMS. I think outside of our own contracting officers, we probably have more conversations with that group, making sure that any of our proposals, any of our innovations, any of our kind of next steps are really compliant with both kind of the letter and the intent of CMS. Again, that's not just WPS, that's across the Mac landscape, because it is a very complex area just when it comes to ensuring that we're all still compliant with the ARS and with our FISMA high boundaries and all of our audits, and our big 912 at the end of the year is really where all that comes together. So I think every Mac, kind of from a security standpoint, tries to stay as much in lockstep as possible. So one thing that when how like Mac contracts work, it's not like the commercial sector where, if we can do a widget for less dollars than, we propose, you can make a profit. In the Mac world with these contracts, we only can make a profit if we excel in the categories that CMS has laid out. So in that regard, when our primary focus is, fast payments, accurate decision-making, high security, very different than the commercial market where you have a very different matrix on kind of revenue and profit. It really is kind of a more direct way to allow CMS to say, here are our goals to benefit providers and beneficiaries, and you will only make a nickel by achieving those specific goals. So it's also a different apparatus. So when you mentioned security, our incentive is to stay as tight of lockstep with CMS security as possible.
It's interesting. And then one of the other areas, of course, on the policy stack is the health IT standards. You mentioned health IT standards, interoperability. We just had the final attachments rule, so some changes around that. So lots of stuff happening there. 0057, as you mentioned, there are a bunch of things happening in that space as well that affect you all as part of this as well.
Yeah, attachments I'm excited about because I see the amount of faxes and paper we get in and the very low kind of utilization we see in the market. I think CMS was very conservative. I think they estimated about 780 million across the entire healthcare landscape that'll be saved. I think we're going to see a much bigger result than that. Just like 57F. When we talk about like fraud, waste, and abuse, the only way to really, really make a dent is to be able to see the landscape. And the programs and interoperability that are being kind of pushed forward through the administration are the ways that we're going to be able to see that. If I think of dual billing between, fee for service or Medicaid, there's a really good way to understand that today. To me, interoperability is how do we take programs that may be regional, whether it's fee for service or Medicare Advantage, right? But yet still broaden the ability to combine those data sources together to ensure that our outcomes are valid, our population is becoming, are we doing things that are making them healthier? And can we tick and tie all of the payments, regardless of what program they're coming from? So I think interoperability is again, well beyond the Mac landscape, but will better the entire healthcare industry. But yeah, we're
Awesome.
excited about attachments. Changes to prior auth are only going to kind of reduce the number of medical records that were coming in, whether it's the prior auth API or the new FHIR standards. So I think, again, that's one of those kind of critical components along with adjudication itself.
Yeah, great. So for folks who are in the sort of innovative space, should they be looking for potentially more opportunities to work with Max in the future? Potentially as Claims Core takes off and there's more push towards innovation. How would you advise sort of policy technical folks to stay apprised of what's happening in the world now that they know a little bit about Max? How should we stay apprised of what's
So
happening?
every Mac is always looking for partners, and every Mac is very much incentivized to become as innovative as possible. One thing, again, that I like about the program and I think does very well to kind of further CMS goals is you've got 7 contractors and we collaborate on things like local coverage determinations. But when it comes to innovation and becoming efficient, we compete like you would not believe. So when it comes to working with partners, every Mac is open to that. I would encourage the best partners out there. Certainly contact me first, by the way, because I'll take that crack at it. But I also think when it comes to these big programs, whether it's Claims Core or 57F, when we have big fundamental changes in healthcare technology, that doesn't close up or say, okay, now we've gotten to the end. To me, that's now the beginning. So whether you're a Mac or a small innovative company, now you're going to have such a different landscape that you can innovate further than what we've had today. So that's why, when I hear, okay, well, Claims Core, everything's going to be immediate and then it's done. And I'm going, no, it's going to allow all of us to innovate more and take like a different lens on something, right? Like when I mentioned the fraud, waste, and abuse, by going to something like Claims Core, it's going to encourage new innovative ways to approach it, new tools, new technology. I think CMS, I thought it was really interesting with Dr. Oz saying that all of the AI agents they have in provider enrollment on the CMS side of the fence, kind of looking to make those connections between provider applicants that, may have relationships with other fraudulent. Okay, well, great. If it wasn't for a combination of AI and being able to tap the PAYCO system, that whole area wouldn't have existed, right? So you have to look at any of these core programs as a way to innovate further than what we have today.
Awesome. Well, looks like we're out of time, but it's been fantastic to talk to you, Brian. Thank you so much for letting us into the sometimes obscure world of Medicare administrative contractors. Hopefully, we'll make that a little less obscure. And thanks again for your time.
Yeah, thanks for your time as well.